Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
My guest today is Dr. Marlene Jabara, who is a board-certified musculoskeletal radiologist, and I think you'll find today's discussion very fascinating. She has developed a platform called RadPod Squad, which is a educational platform for anyone who's interested in lower extremity pathology and corresponding radiological imaging. What I find so interesting in Dr. Jabara's expertise is that she has a very deep understanding of biomechanics and is able to put together her biomechanical knowledge with her knowledge as far as interpretation of different studies, MRIs, plain film, radiographs, etc., which gives the recipient of that imaging report a little bit more insight, and she understands how complex the foot and ankle really are when it comes to pathology and appropriate imaging and, more importantly, interpretation. So please enjoy this conversation I have with Dr. Marlene Jabara. All right, I'm here with Dr. Marlene Jabara, and she is a musculoskeletal radiologist who has a great focus in podiatric medicine and pathology. Before we get started and get down into the weeds with what you're doing, tell us a little bit about your background and how you got to this point, because I think it's a real interesting story.
Thank you so much, and thank you for bringing me on the show. It was an honor to receive this invitation, and I can't say enough with how wonderful it is to collaborate. And I think that is what really got me into medicine. I am a board-certified American radiologist with a subspecialty expertise in bone and joint radiology, and furthermore in foot and ankle. And I was trained by an amazing radiologist his name is Dr. Javier Beltran, and he was from Europe, and he always impressed on me the importance of locomotion and walking and understanding how to read images in motion. And that was different from everything that we were doing. I was originally trained in Brooklyn out of downstate, and we learned, like all radiologists, how to find the anatomy. We went to the anatomy labs and we learned how to interpret images. And it wasn't until I got to my fellowship with Dr. Beltran where he began to impress on me the importance of understanding how we walk, how you throw a ball, how do you move, and how can we look at imaging through that lens. So lo and behold, just like all of American medicine, we get out there and we learn how to interpret images, and we're just learning how to read the images and understanding what it means to have a turf toe and things like, the clinical part. But for the most part, radiologists are behind the scenes looking at images and somewhat removed from that patient experience. So I became interested in bringing that together.
Well, one of the things that I think radiologists have a very distinct disadvantage is they oftentimes don't have the ability to actually see the patient and palpate where it hurts. And, so they're, just by the nature of the way that the specialty is, it's sometimes like having a little bit of a blindfold on because you don't get this. So I think that says a lot with what you're saying as far as integrating the biomechanics into what you're looking at, because let's face it, these are dynamic structures. They're not static structures. And that type of understanding is going to give you the ability to help everybody else in your interpretation. So I think it's great.
Thank you. And that brought up early in my career when we were learning, one of the most important adjuncts to my training under Javier Beltran was ultrasound. And that's where a radiologist first gets that opportunity to actually interact with the patient and also interact with the team.
Right.
So we began early on looking at, in the foot, especially, we began looking at just the plantar fascia, looking at touching the fascia in the ultrasound suite with the probe. And I became very interested in how important it was to actually touch the patient, put that together to understand the common complaints over time. Mm-hmm. And then furthermore, for a radiologist, it is not the way that we tend to sit behind a screen reading images. Doing ultrasound takes that active advance towards the patient, and sort of you're acting almost alongside a podiatrist. In fact, I used to think we should have clinic where we have a radiologist next to the podiatrist. The podiatrist does their initial consultation, and then we can corroborate that on an ultrasound. These are systems across the world, by the way. They do that in London and England. I've seen that where that happens. But as a mainstay, radiology has not initially gone towards that patient unless you are in ultrasound.
Right. So we've got a lot of great stuff to dive into today. Going to talk about your platform and the fact that, this knowledge base that you have, you are sharing it with these practitioners, which I think is fantastic. You want to tell us a little bit about your platform so that they kind of get an idea of what they can get into. And then let's specifically go into the forefoot and talk about plantar plate, because I think there's so much that we could talk about. We could probably do 10 episodes, but let's just focus on forefoot plantar plate for today. So tell everybody about Rad Pod Squad.
Sure. So in my career, I'm an experienced academic radiologist. I spent, a number of years in New York under Northwell. And I began to see as a radiologist early between the years of like 2000 to 2010, that the amputation rate was through the roof. And I was sitting in a room reading MRI after MRI, wondering, are we making any difference? Because it seemed that the amputations would just continue. There was nothing we could do. I looked at the guidelines from the American College of Radiology, and they suggested you get an early MRI when you see a patient who potentially has osteomyelitis. And I began first, honestly, with a bit of a bias. I said, why are we not doing better here? Like, what's wrong with us? And I decided to start with a research project that had me studying about 500 patients who had diabetes, who already had an amputation, and whether or not they got an early MRI. Did it make a difference? Was MRI a game changer? And I didn't find at the end of my research that it changed the amputation rate, but it decreased the death rate. And that's in diabetic foot and ankle. You can take a look at that. And I surmised that the reason why we were decreasing the death rate was because now we were talking to one another. The surgeon was talking to the radiologist, and we were all collaborating together. And I always had this idea that one of the things that was occurring in medicine was I wasn't seeing the podiatrists enough. I wasn't interacting with them. I didn't see where we interfaced. I went to grand rounds and I gave grand rounds, but I didn't always see the podiatrists in the loop. And it dawned on me, I need to know who they are, because how will I ever know the clinical really well, or how do I even know where an ulcer is? Now, for those of you who may not realize by now that having a foot ulcer is the predisposition to having osteomyelitis, and that it may cause you to have amputations, which may cause you to have years of your life removed. So it's a very important strategy. And I began to wonder and want to make a collaboration directly from radiology to podiatry. And I created a 24 lecture series that was commended by the American Academy of Podiatric Graduate Medical Education, and all the residents in Northwell of 14 different hospitals had the ability to come to my course, check out my lectures, interact with me, and we saw through polling that they did much better. And we brought in new systems. We even were able to create a system where we had official text-based photo language where the radiologist could see the ulcer when they're reading the case. So we developed all that with wonderful results. But to take it up a notch, what I wanted to do was to really talk globally to the problem that we have in diabetic foot, but just in foot and ankle imaging in general. We do a lot of imaging. Imaging is one of the most important reasons for patients to come into the system for foot and ankle issues. And we want to do our best so that we really can understand how we're going to treat the patient. But if we only have one side of it as a radiologist, just having the pictures, we don't always appreciate the tremendous clinical features. Like in forefoot, you mentioned, a podiatrist can see very quickly that, say, that the second toe is starting to cross towards the first toe, as in a case of a classic plantar plate tear.
Right.
But a radiologist was never trained up through that area. So it may not be obvious that we should be looking for that very quickly if we want to make that diagnosis, right?
Right. Well, and I think because of our specialty and peripheral nerve, and we end up seeing a lot of folks that have had failed Morton's neurectomies and different types of devastation surgically induced from the standpoint of attacking the forefoot with all of these different things, where I think if they were able to have a little bit more appreciation of what you're pointing out, like increased, like say they have a long second, third, and fourth metatarsal, and they have an equinus component, they're pretty much doomed to a high pressure event in that forefoot. And there's not many radiologists that I know of that will say, like you, well, look at the cortical sclerosis in the second metatarsal. That's a very objective finding because of a biomechanical event that's going on in this particular patient. So it gives you a little bit more understanding of, everything that's going on. And that type of, just that verbiage in one of your reports is going to change maybe the way that podiatrist or foot and ankle orthopedic surgeon is going to maybe look at that, and could totally change the care that's rendered and the treatment path that they go down. So I think that's an important thing. So they can go, and we'll get more into this at the end, where they can go and join your community and everything. But we wanted to talk about plantar plate specifically.
Yeah.
So do you want to share with us the case that we're going to put up?
Absolutely. I'll take you through, and I can already introduce you to the community by seeing the, let me take you through some of what I've got going on here. So not the invitation, let me get rid of that. So when we talk about what I'm trying to do is basically it's a fellowship that many radiologists, I already trained radiologists across the globe. And what I'm looking at specifically is to create a foot and ankle fellowship program, which I've called RadPod Squad. And there's a whole community where you get to know other physicians and we discuss cases as they come up. In my classroom, where you get to have quite a bit of content. There's tons of lectures on every aspect of podiatric radiology, and it's geared that we're all learning the same way, like what we all need to know, what the radiologist, what the podiatrist, what we all need to know to get to treat our patients well. Specifically in forefoot imaging, I have had, for years I was talking about something called pseudoneuroma, and I was called into the office and asked, what are you talking about? Did you type that incorrectly? And we've known a lot about forefoot imaging and the different problems with nerves out there, but it's been slow to change the medical establishment's ideas. So I create this RadPod Squad to enlighten and to bring out some of the features of what we've been studying and bringing all the important players into the same room. In order for us to impact forefoot disease, we need the podiatrist, we need the surgeon, we need the radiologist, we need the whole foot care team to understand. And what we're understanding, like in an example like forefoot plate, I basically have videos that can take you through that. But just for the sake of time, just looking at a static lecture, and this has been videotaped, we're looking at the plantar plate. As we know, the plate is responsible for the metatarsal purchase from the heel strike to the early to the late flat foot phase to the toe off. We're using those toes to really toe off. And when they go bad, right, we can wear out a plate and it can pop up and become a crossover. What we're talking about in the biomechanics, what you were alluding to, is being able to interpret your x-rays, being able to see hammer toe deformities and translate that to the doctor who is not looking at the x-ray, who we can start to understand how we can grade and do better work with understanding where our patients are at. And I use this X-ray. X-rays tell us a lot about our biomechanics. As you had mentioned, if we have, say, elongation of the second toe, or even if we have the plantar plate for the first, if the sesamoid's on a different line, and all of these features of cortical stress and deformities and splaying are not things that you see in a typical X-ray, but you want them to be, because they really make the difference of where you're going to stratify your patient. Now, and I'm an artist on the side, so you'll often see things like my pictures of what all of the anatomy of this are. But in studying the plantar plate, I think it's important for a radiologist to have all that background, to understand all that clinical, and for the podiatrist to understand what they can expect from a good report. We put together protocols that really help us to see the plate. Now, this is what you can see on MRI. And I think once a podiatrist understands what they're seeing on MRI, it becomes an important part of their surgical experience. Right. If you're going to take a scan of these regions, you want to understand what you're cutting and what you're doing. And in the past, we would just bluntly dissect down into the dorsal space. We would take out what looked like an X-shaped nerve, and we would put it in the can, and that would be the end of that. Now, we clearly know that there's a lot more involved anatomy than meets the eye, and that may be in large part for why these plates don't always do well long-term, and why a nerve procedure may not do well. And really, it's even more complicated than just learning about what's there. It's learning about how the hind foot is loading the forefoot, as we've mentioned. So at RadPod Squad, we routinely go, this is content that's available to anyone, any day. But the real benefit in the community is really asking questions like today. We just see this right here. Today, a student was asking me about a plantar plate. This is a student showing me an MRI. Now, one of the things is I train people from all over the world, and all over the world, they do things differently. So this is a very wide field of view. It's not the best field of view just to see the plate, but you can see the great toe. Mm-hmm. Essentially, we're looking at the sesamoid. This is a fat suppressed image, but we're looking at the great toe, and you're seeing the sesamoid and some of these ligaments. Where we're looking at the nerves themselves, we can see if we look at the metatarsals in the short axis. I know that you don't know that, and if you want to know more, you're going to join radpodsquad.com. But we'll be looking at these reasons for why the metatarsals are looking this way. And one thing I pointed out to this student, or this physician, was that even though the doctor was interested in a plantar plate tear, take a look at the hindfoot. Take a look at the edema that's around the posterior tibial tendon. Appreciate the fact that this patient actually has some form of pes cavus. They're not actually flat-footed, and we can see that on a non-weight bearing just from looking at or trying to guesstimate where we think is the talar vector and comparing that to the first metatarsal vector and have normal Meary's line. So very important to load and understand the hindfoot before you go and take out an neuroma in the forefoot, because this cavus, if someone does some sparing procedures here, they're going to have less and less forefoot metatarsal purchase to accomplish their phase of gait. So right. There's a lot of complicated stuff as you step. I could add 10 hours to our time together, but I wanted to just share that it's very complicated. And I think in community is where we can really, really bring this together. And that's where I encourage people to join the RadPod Squad to discuss cases and to, this is a great example as well. This was a student the other night. Hi, Marlene, can you give me advice on measuring hindfoot valgus, Salzman view? I have a referring foot surgeon who asked for them, and he's admitting none of his colleagues understand what calcaneal line to use. Right. So now we're getting to it. You know, what people don't know, and I'm able to share with them where this literature came from, how to measure it, and how to talk to their physicians so that we make a difference and help the physician to understand how to balance that hindfoot alignment view. I'm going to stop for a second. I think you had a question or a comment.
Well, no, I think that, when we talk about forefoot, you have to appreciate the global nature of what's affecting that forefoot, and you have to look proximally. Do they have an equinus of some type, gastrocnemius or gastrosoleal equinus? Is that causing an overload on the forefoot? Have they given a bunch of steroid injections that really do nothing from a standpoint of improvement of the outcome for the patient, but yet it will erode the plantar plate? So maybe their, quote, neuroma-like pain gets improved, but then they come in with a hammer toe. So there's a lot of things that are going on that you pointed out, but you have to look at these not just from that little specific area of tissue, but what's happening proximally with that patient from a biomechanical standpoint that's causing that tire, so to speak, to wear out. I use the car analogy an awful lot because people understand it. And it's like if you have a tire that keeps wearing out on the passenger front side of the car, well, it's probably not the material of the tire or the tire itself. It's probably it's the alignment. So why would you just continue putting a new tire on this thing and not try to get it back into alignment? I think that's what you're saying here.
Yes. And I think it's much more complicated than meets the eye, which is where I think each group purports to have the answer or the best way to look at it. And in fact, it's a fallacy because no one group alone, whether you're a podiatrist or a radiologist or anyone in the field, together we need to understand all of the biomechanics in order to understand what the imaging is showing us. But classically, this is very complicated. There are multiple features. When you think about the foot and ankle, 28 bones, over 30 ligaments, a lifetime of blisters, right? I mean, there's no end to the complexity. When I tell my students, I'm going to teach you, there's a medial column and a lateral column, they look up to the sky because these are radiologists who are extremely brilliant. Are you trying to tell me that I don't know this? But the point is that, just like you said, it may not be obvious, but when we're doing something like a hallux valgus repair, and we have not fully understood all of the hindfoot alignment or all of the forefoot alignment or understood, does the patient have, confounding issues or are they at risk? That's a really risky thing to just change the hallux positioning without going through all of it. And we're beginning to see those failures in diabetes. Like for patients who early on had biomechanical failures, once you get diabetes, now you're on a locomotive train to a wall. And you really want to understand, we've done some studies to understand the foot alignment ahead of time, but this is where in RadPod Squad, we basically will take you through some, you need to get into the angles. You need to sort of see what you don't know. So there's wonderful tutorials of how we take these x-rays. Now, I'm not training someone how to take an x-ray. I'm going to train you in interpretation, but having excellent technique is essential. Right. So, and I tell my students, we don't know everything. I don't know everything. So having a flexibility with not accusing someone or asking questions, you want to come and ask your questions. You want to not be afraid that you're the only one who's not doing it right. We want to get to the right position. It took a lot of people, naysayers, telling me, oh, Marlena, you're just hallucinating. What are you talking about? I'm like, but no, it really seems to make sense that a lot of people with hallux valgus seem to need it. They already have a pes planus. I don't know. There's something to it. We do need that compensation. So I'm not sure what's the right answer, but in the future with AI, it will be very possible that we can marry something like a gait analysis to a mobile MRI and understand exactly the changes that occur through the phases. And there'll be lots of information that a computer, so we want to understand how to guide that. No, and I think that's what RadPod's going.
That's great, because now if you look at an x-ray of a patient that doesn't have a significant amount of osseous deformity, you really don't have an idea necessarily what's going on with that plantar plate if it's early. And that's where dynamic ultrasound can be so valuable, because you can take and you can stress and see if they have a positive Lachman sign, and you can see that plantar plate just open up. And I've had so many MRIs that have come back and they say, there's no issue with the plantar plate, but you can take the patient's foot and dorsiflex or dorsally sublux the proximal phalangeal base on the metatarsal head, and it might be a 6 millimeter gap. But there's no way that the MRI is going to pick that up because it's a static MRI. And so, when the foot's in a resting position, that plantar plate isn't being stressed. So a lot of times it floats under the radar. I don't know how you feel about.
I do. And in RadPod Squad, this whole section, I don't want to take you through the volume of it, but what I wanted to show you is that I trained and created podiatric systems in hospitals that help people to understand how to use ultrasound as an adjunct. Or I even have podiatrists that graduate and come back and want training on how to bring that to their office. I'm not necessarily, I think that there has to be a lot of training to understand it, but having the podiatrist who knows the patient, who knows how to stress this Lachman's maneuver, who's been trained clinically, you can really see, here I'm just demonstrating a Mulder's maneuver, and there's more to it, but basically you can see this hypoechoic nerve that's going to plunge out of the space as we go up and down with our Mulder's sign. This again is looking at one aspect of the total issue. So when I think about ultrasound, I think about it as problem solving. And what I want to do is I always really prefer to have some baseline high quality MRI ankle and foot. And then we use ultrasound to understand where to put our injections, what we're looking at, how dynamic it is. And I agree with you. It can give us, I have ultrasounds as well on the course that help us about Lachman's maneuver. I think these are essential parts of your training, one's training to understand how we're going to impact these diseases and how we can talk about them. I think that, we're all looking at the same thing from different parts of the steering wheel.
Right.
But putting it all together, I think you need a map, you need good X-ray evaluation, you need to be astute at understanding the biomechanical disadvantages that occur by being able to predict the biomechanic. And then we want to talk about which the podiatrist is in perfect position. How do we treat it? Do we do surgery? Do we do offloading? I think prevention is going to be a key player in the future. And being able to predict the best offloading is going, this is all available. Imaging is going to move into AI, and we're going to be able to put it all together. But for the podiatrist who really wants to get a head start at where we're going in the next decade, I think this is where it's at. Understanding dynamic imaging and marrying that to your clinical practice, and even bringing your patients into the picture, showing them the picture. It can be an amazing visual thinking strategy. I believe you if you show me something on the picture, like show me where this is.
Right. It's amazing how good patients are in understanding their ultrasound imaging. They don't need to be a radiologist to see that gap in the tendon or to see that subluxation of the base of the phalanx on the head of the metatarsal. They get it, and they can, I think that really imparts a lot of very important information to the patient that actually helps them in their treatment course, because once a patient really gets a grasp of what's going on, it's easier for them to say, okay, I'm going to buy into this. I'm going to do everything that I possibly can to get this condition better or improved. But if they don't understand it, it's just this nebulous thing like, just take this pill, the compliance isn't going to be as good as if you really educate them and get them on board with you. So it's amazing how, especially with a larger structure like plantar fascia, it's very easy for them to see a degenerative area in the fascia itself on an ultrasound. And then you can show them on the contralateral side, this is what it looks like on the foot that doesn't hurt, and that really is very powerful for them. It empowers them with knowledge of their own physiology.
And now a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today.
I agree with you. And I have other interests that look to how we can increase patient engagement. And a lot of doctors, we're tired, we're burned out, we have a lot of things on our mind, but it can be hard at the end of the day to take more time with each patient to explain it. But I think you can effectively find strategies to explain it, and you can even empower members of your team to help with the patient to explain why this is important. And I think that when people get concerned about their own health, they're in a great position to impact their own health. And absolutely using the image to explain, just like a gastroenterologist, when they do a colonoscopy, you get little pictures that show you the polyp that they removed.
Exactly.
At the same rate, exactly. Now, anybody can show you anything. So I don't want to use it as a technique to just get someone to get something. But I really think that I think many people can appreciate a picture, that they can see what you're trying to do, that this is too thick, we want to get it thinner, we're going to try these maneuvers, but I need you to wear your boot, or I need you to do those stretching exercises, that you want to enroll people as the team. You're not going to be able to handle any doctor, and it's unfortunate because podiatrists get some of the sickest patients. Diabetes is the 7th leading cause of death, and the diabetic foot is in the billions of dollars as to what it costs to manage it. So we are in the trenches, and we have to find strategies that help our patients get better, but also help us feel we're doing something that makes a difference for us to do this over time. And that's why I think building a community with using radiology for a million reasons, not just the excellence in the imaging or the excellence in the care, but the community and the collaboration, you have backup. We can talk about what we see and what we're going to do before we get to a point where, things are failing. Many of the surgeries predictably can fail if we don't pre-strategize the best patient selection. And it may not be obvious to you that just looking at an x-ray or an ultrasound is not enough. No matter what you think, it's not enough. You need to understand how the hips are even loading down. So I think we need to work in teams where a good podiatrist is going to have a good physiatrist, a radiologist they can talk to, an ultrasound, somewhere in their world, because for the dynamics. And from there, they're choosing who they're going to operate on, who they're going to do conservative procedures like injections, where we are and what we're doing. And people are going to get better around us, which is going to make everyone happy, not only emotionally, economically, globally, for our health. It makes a difference.
Let me ask you a question, because I think you brought up many good points in that last little discussion. But have you seen... I'm going to
stop sharing for a second. Should I stop sharing?
Sure, if you'd like to. So now here's a scenario that we see as tertiary nerve specialists. We get all of the crazy stuff that has happened down the line, and they've seen multiple practitioners. And one of the things that we see more commonly now, and there's this divide of philosophy in orthopedics as well as podiatry about, if you have somebody with an arthritic condition of the first metatarsophalangeal joint, there is the group that wants to do a total joint implant, and then there's the other group that wants to fuse this first metatarsophalangeal joint. And we rarely see people that have serious complications 1 year, 2 years, 3 years post-implant arthroplasty, but we see a fair amount of people who have developed lesser metatarsal pathology because they had the first metatarsophalangeal joint fused. And as you alluded to earlier, this is a very dynamic, big load-bearing joint. And if you take that motion away, at some point down the line, you're going to end up paying for it. And it's just kind of interesting. I don't know if you've seen any sequela from fusions of the first metatarsophalangeal joint, but we see a lot of them.
Yes, I just this morning, one of the radiologists from Greece brought a case. They did a Chevron procedure, and the patient has first MTP pain, and we were looking at the case together. the case was complex in that the metatarsal head, the chevron procedure, the metatarsal head had an osteochondral defect and went on to have osteonecrosis and edema. I can show it to you if you like. And the chevron screws, one of them was actually perforating to the sesamoidal follicle complex. What happened first? Did the chevron fail? Did the head already have an osteochondral defect? What exactly is the chicken or the egg? Just in that one chevron procedure.
Right.
At this point, it's clear that the patient, the usual state of affairs in this case would be to fuse that joint, to decide to fuse it or to replace it.
Mm-hmm.
What I explained to the doctor, on the second plate, we already have early crossover.
Right.
So doing something right now, thinking of the long stream, the person was 34. So this is a 34-year-old who is presenting this way. And this means that for a long part of their life, they could be at risk if they get diabetes, if they can have a lot of issues. So this is not a small thing.
No.
And I see that there's complications. I think it behooves all of us to understand our preoperative strategy without a doubt, to understand that it's going to, whatever operation that you're going to proceed with, you want to protect those lesser metatarsals either through rigid orthotics that have already built-in pads. And this is not my area of expertise, but I've spent enough time in podiatry that I can tend to see what the orthotic might need just from looking at the static image, but it's going to take those pressure-sensitive areas. But without a doubt, to do a chevron or to do any of these forefoot procedures, you need a hindfoot workup. I think it should consist no less than a gait analysis, hindfoot and forefoot MRI, just to understand your baseline, how much cartilage you're beginning with, and then understanding what's the post-op plan. It's not just to get the hallux valgus and walk. It's going to be hallux valgus, dedicated plus orthotic. And you're going to need to know your orthotic specialist like your best friend. It's going to be essential that you understand when you're pregnant, even if a woman gets pregnant, the
Right.
changes on the stress on the foot, the changes in the hip, those are dynamic things you need to be, this is important. Just like you're getting a blood pressure check, you're checking your balance biomechanic all the time so that you're recognizing where it's drifting. The good news is that it doesn't happen overnight. Like you mentioned, a year, 2 years, there's
Right.
time. There's time to work it up, and there's time to work it up properly. And I think if you get better patient selection and understand your offloading, you're going to see that your forefoot procedures do better and last longer.
Right.
When I have forefoot problems, and one thing I learned when I was young, I went to a sneaker store, and the woman said, you're having trouble in the front of your foot, but maybe you should get a sneaker that you sit deeper into the back of your foot. And this was years before I understood about biomechanics. And I think about her now, how lucky are her clients, people that came into her store, that she helped offload, that she was already recognizing in the sneaker industry just how people are. That's what we need to do. We need to really take heed and notice that. And we say we do, but our weight-bearing x-rays, they're not really properly obtained.
Right.
Our gait analysis are asking people need to be part of this. Just like I want them to have, just like they know their medicines, they write them down. They bring their sneakers in. They have them in a box that they know they can show someone what their biomechanics are doing. This is essential. There's no way around it. As a radiologist, we see all of the insides, but you need the outsides as well. But as a radiologist, I've also learned that you can make those relationships just by asking the podiatrist or starting to do ultrasound. I've trained physicians, throughout my career, and the complaint that they say is that there's no time for this.
Mm-hmm.
There's plenty of time when you're in the lawyer's office dealing with all of the messes. There's plenty of time to get disillusioned about it. I know that it takes time, but what I'm trying to do is to find the inspiration and motivation. I love what I do because I keep learning about it, and I'm learning from all of you. So I think there is a place for this, and I'm glad that you asked.
Well, I think you make some really important points. And one of the things is, let's say they do have a very degenerative first metatarsal phalangeal joint, and the surgeon does a fusion, and that patient does very well. But they do very well maybe for the first 6 months to the first year, but they had a long second metatarsal, and they didn't address that. So now, a year down the line, they come in with either a second interspace neuropathy. I hate to use the word Morton's neuroma. That's a whole different discussion on itself because it's a nerve entrapment. It's not a neuroma until you cut it out. But I'll never get that message through. I've been, bitching about this for 30 plus years. But long story short, many times with these procedures, you're kicking the can down the road, and you may feel like, man, my patients are, I'm doing a lot of these fusions. They're doing awesome because they don't show up until a year, 2 years later, or then they show up someplace else. And it's like, well, this is a whole new problem. Well, the answer is no, it's not a whole new problem. It was a problem there that was waiting to happen that you just didn't take the time to either acknowledge or you were ignorant to its presence at the onset. So I think there's a lot of merit to what you say, is that you have to look at these things globally because we're not very successful when we just treat a symptom without understanding why that symptom is occurring in the first place. So my hat's off to you for that. What about intermetatarsal bursa? I wanted to talk about that because I have some suspicions about that, but I'd like to hear your input on it.
Sure. In terms of the intermetatarsal bursa, that's basically a space that exists next to the neurovascular bundle.
Is it inferior or superior to the deep transverse intermetatarsal ligament?
It's superior.
Correct. And the neurovascular bundle is inferior to the deep transverse.
The neurovascular bundle, so the deep transverse intermetatarsal ligament is a band that goes along the plantar aspects of the metatarsal head, and it would be good for me to share my screen and show you pictures of that. But
yeah, sure. Do that.
I think I'll do that.
And it's my understanding that the TIML is really a confluent structure with the plantar plate. It just joins into.
So let me just get to the classroom, and I'm just going to go. I have a lot of my videos are videotaped, but we have. Let me just open up plantar plate, and I'm just going to look to the normal anatomy. So we first want to qualify what we're talking. You asked me originally about the deep transverse intermetatarsal ligament, and what you can see what's going on here. This is a great anatomic drawing. This is basically this is the lesser metatarsals, M2, M3, M4, taking you through I call them these the penguins. These are my penguins. What we have, if we look at I made the second bigger, but that doesn't make it, just taking a look. What we have are you're going to be the tendons that reinforce the capsule, the proper and accessory collateral ligament. This is the region of the plantar plate. This is your flexor tendons, your digitorum longus, and your brevis. You can see there's a band that goes underneath the metatarsal heads. It does not come out to the proximal phalangeal level. So at the level of the metatarsal bands, this is a reinforcing structure to help the accessory collateral ligament support the plantar plate.
Right.
What lives here, this right here, is your bursa. It's superior, it's deep, depending on which you're looking at. If I'm looking at the plantar, you have to qualify everything you say.
Right.
If I'm looking at the plantar surface of the foot, what you can see is that I have a neurovascular bundle here and I have a neurovascular bundle here, and we're at the metatarsal level. But this is your intermetatarsal bursa region. Mm-hmm. Technically, neuromas in general are fibrous changes surrounding a nerve. If it's said to be in the midline and that we have a neural enlargement that's coming through this region, the neurovascular bundle is actually there on both sides, but what happens is if it's in the midline, it can be large in the midline, be dumbbell shaped. We'll call that a traditional Morton's neuroma. If it's hanging on closer to this, if a neuroma is hanging on one of the sides of the capsule, that's a pseudoneuroma. And that's a term we give to recognize the fact that the neuroma or the fibrosis, the perineural fibrosis that used to be called neuromas, are basically a part of the plantar capsular problem. And so we used to just treat neuromas until we realized it's not the neuroma's fault. It's the metatarsalgia likely coming from the plate. But to speak to your question regarding the anatomy, the bursa is a potential space. This is actually the gross anatomy, just looking at the plantar plate itself. The plantar plate is a fibrocartilaginous structure that I've indicated here by that low signal band. Well, I could talk about this forever, but what you're seeing here is a deep transverse intermetatarsal ligament. It's the band at the level of the metatarsal heads that will connect one metatarsal head to another. And you can see it a little bit better here.
Right. So I guess Marlene, my question is that the bursa is superior above the transverse intermetatarsal ligament. The neurovascular bundle is below the deep transverse intermetatarsal ligament. And my question is, when you see some of these radiology reports, they'll say a large bursa in the third interspace, okay? And then when I see that, I want to look and see where this is on the image itself. And my question is that really dealing with the pathology so much? Because it's really kind of, if you think about it, it's in the neighborhood kind of on top of where our stuff is going on with the Morton's entrapment. And then my other question is that if we have a partial plantar plate tear, obviously there'll be some extrusion of joint fluid. And is that sometimes picked up as an intermetatarsal bursa, or are they always distinctly separate? I don't know if I asked that question very well.
Yes. What I wanted to do, as you were asking, it would be helpful to see an actual image that will help us to talk about what I hear what you're saying. One of the things I hear you saying is you get something from a report, and is that really the issue? They see an intermetatarsal bursa, so what?
Right.
That's
my question.
Problem generator. One of the things altogether I think that we need to get clear on is what are the pain generators? And I don't think that that's a simple question. I think that we can talk about the pseudoneuroma, we can talk about the plantar plate issue, we could talk about the intermetatarsal bursitis, but there's pain and then there's dysfunction. Mm-hmm. Pain may not be the worst part of this. Removing the pain may be a treatment strategy that we employ, but have we changed the marching dysfunction that's going on about, like what you said about the tire, that just changing the tire, it's not the material of the tire that's wrong.
Right.
So I think when radiologists, one of the problems is that we don't know. I think that a lot of people don't, when you're trained, you don't know. You think you know. We think we know what causes pain. We think if we see a fracture with edema, that's the pain. Right. But there are things we don't know. And one of the things I don't know is about what is the significance of intermetatarsal bursitis, because it's not there by itself. But sometimes there's a few problems. Your imaging may not be showing a plantar plate. This exam came from another country.
Right. And
you can see that it does not have the resolution that I need to see some of the features, to be so specific about where it's. So here I'm looking at I'll just zoom this up. It's not the greatest example on earth, but we're looking at, the plantar plate, and I really can't even discern. I know that this is the region of my collateral, this is my accessory, these are my flexor tendons, but I don't see anything inside of them. It can be that the radiologist didn't even realize that the resolution isn't there to see all these structures. And so what? I see some intermetatarsal bursitis here. Is that all that is, or is that actually a neuroma? So in the first interspace.
And I would ask you, or I would say it would be very difficult for me to believe that is part of the neuroma, which I hate to use that word, but let's call it the nerve entrapment, because anatomically it's in a distinct area from where the neurovascular bundle is running. So that's where I'm having some confusion. That the other thing is that we did way back, probably early 2000s, is that when we suspected a plantar plate rupture, we would inject the joint with Omnipaque, and you would see this. If the plantar plate was ruptured, you just see this big Rorschach blot where the Omnipaque would extrude into the adjacent tissues. And then, interestingly enough, we wanted to follow that up. What happened if you just did a metatarsal osteotomy without any addressing of the plantar plate? And we had a handful of patients where at 3 months post-op, we injected with the Omnipaque again, and they had this nice little crescent moon. The radiopaque dye didn't go anywhere, so it kind of confirmed that planet plate had healed by eliminating of that pressure. I thought that was kind of an interesting thing, but in a couple of cases I can remember, you could see that dye actually extrude up into the inner space where these bursa are, and I was thinking, well, is there some fluid coming out of this metatarsal phalangeal joint that is somehow extruding up into the inner space? And is that maybe the bursa that we're seeing? And I don't know. I mean, I'm just asking you for your experience on that.
Well, one thing I can tell you is that I don't think they're exactly in isolation. And just because they don't live as close as you think they do, I think in dynamic walking, a lot of these relationships change depending on how much crossover, how much flexibility you have in the forefoot, and what your tissues are, how close these metatarsal heads are together. There's a lot of features. There's a lot of variation. But when I'm looking at a patient, what I'm trying to determine is really, do you have a real plantar plate tear, a gap? If you don't have a plantar plate tear, I want to understand where the degeneration is. I'm not as super concerned about the fluid per se as I'm looking at the structures to understand how I can grade them biomechanically so I can let someone know we're wearing out here. This is where it's wearing out, where either at a tear. Yes, a lot of them have pseudoneuromas. In fact, almost every case I read that has forefoot pathology is going to have some amount of neural fibrosis around it. That's the natural course. But in terms of things being contiguous with one another and defining an actual break and tear, you can do that with excellence on MRI, looking at a defect in the plantar plate. And there are many researchers that do that very well. Now, average radiology across the board, if you're not scanning and you're not seeing these every day, it takes a special amount of training to read forefoot or ankle very well. We know that.
Right. No,
so that's part of it. There's a mixture of questions you're asking here, but just because I have it, so when you talk about the deep transverse intermetatarsal ligament, just to speak to that point, the deep transverse intermetatarsal ligament stops at the level of the interspace. Right. So you can have a nerve that is bigger and floppy and going up over its region, and that's where we begin to see that H-shaped or that X-shaped nerve. And I don't have a great example in this case, but this right here is your interdigital nerve, that hyperintense change you're seeing there. And what I can tell you is that it's more of the presence of what the plantar plate's doing. For this student, what I was explaining for this 34-year-old patient, what was more concerning to me was the amount of pressure that's going on her great toe. See this pressure point? Mm-hmm. And there's also one under the fifth. Right. One thing that we can help the doctor understand is that this patient needs offloading. And look at how perhaps uncompensated their biomechanic is right now. And why is that? And that's what I was explaining to the student. If you as a radiologist are not paying attention to the hindfoot, don't recognize that the patient might have an extra-articular coalition. And that's what they have here, that they keep they're in their uncompensated state to try to maintain on Cotton's triangle. They have a very rough forefoot biomechanic, I call. They're really slamming down on that hallux. And so where we can even see where they're slamming on it because we can see the pressure point. What is the treatment at this point before anything tears would be to get this forefoot mechanic aligned to the hindfoot.
Right.
And use this information here to begin, because one other thing I'm worried about in this young patient, if you look at the fat and the muscles, there's a lot of marbleization of this fat. I mean, that's what we get paid to do as a radiologist, to tell you this. You don't need to know that. I'm not here to train a podiatrist to replace me. I'm here to work with them so that the patient gets everything they need. And I would say most people wouldn't expect a 36-year-old female to have neuropathy, but I absolutely see that every day. If you're a Hispanic or a person of color, you have early stages of neuropathy. That may be what's adding to this person's problem. So let's just say at 36, they're pretty healthy. Let's do procedure here. This patient presents with a neuroma, we'll do something.
Right.
And they begin to operate, not realizing all along this is the early stages of neuropathy and like global neuropathy. And we really need to deal with the whole person right now. So there's a lot riding on a podiatrist to get the answers correct. And there's a lot of fallout when they don't. And I don't think it's fair on either side. I don't think we're giving ourselves enough of a chance to learn the way we need to see all the modalities together to make a difference.
No, that's a very valid point. And, I just had a patient earlier this week that had been up at Emory, Johns Hopkins, had a definitive hereditary-based neuropathic condition, but yet all of the symptoms were solely in the forefeet bilateral. He had no symptoms virtually anywhere else. So now what you have to say is, okay, do we have a superimposed exogenous nerve compression because of the abnormal biomechanics? And that's what's fired. Is that what's firing him up rather than this occult genetic neuropathy that is magically not affecting anywhere else in his body? So you have to put all this information together. And
yeah, and there are many neural syndromes associated with foot syndromes. And you realize this because when I deal with surgeons who deal with the most difficult feet cerebral palsy patients and congenital issues, they're always the spine surgeons as well. There's a relationship of understanding how elegant and important all of these structures are. And I have seen some of these idiopathic neuropathies but the most important thing there, again, is even with all of that, understanding where we are, what we have to do to balance it better so that we're not driving it to get worse. And it may be that eventually the whole forefoot needs to fuse because a lot of these patients have such terrible muscle tone. It's very floppy and they're going to get ulcers and eventually, amputation. So I think it behooves us to understand more and more, not just for our everyday person walking around looking for a good pair of sneakers, but for all of the reasons that, diabetes is the 7th leading cause of death in America. I mean, there's no question that this understanding the foot is a cornerstone of getting some life longevity on that patient. Because when you get a transmetatarsal amputation rate, you may look at mortalities that are elevated a third to 40%.
Oh, it's normal. It's incredible. I mean, if you look at the mortality after a BK amputation, there's maybe 2 or 3 diseases that are worse for your five-year survival rate. And, so it's a very big deal. Marlena, we have got to get people to your RadPod Squad platform because I think you have such an awesome, this stuff is really empowering. And I would encourage all of our listeners to really go and connect with you on this. I think what you're doing is fantastic. I want to bring you back and talk about imaging of the heel because that's kind of an interesting thing. I think that would be really fun. But for this one, let's wrap it up with you telling the audience where they can go, how they can connect into this awesome forum.
Yes, the quickest way is to just go to radpodsquad.com and it's going to ask you to join the squad. And I'm offering a freebie where you can get a bundle of 3 lecture set of learning to look at foot tumors, which everybody could use more experience with looking at foot tumors, and a few other things in there. And as you can see, I want to empower us all. And I really think it's hard to do when we're already worn out and burned out. So there's a little inquiry in my freebie to ask you some questions. Are you getting enough sleep? To start to get your own inventory of how you're going to help yourself right now to be able to want to get into a program of learning to help others. I think it requires like a mind-body connection. And lastly, grab your popcorn and you can get a case sampler, but go to radpodsquad.com. If you feel that you've seen enough and you love it, just join the school. And for $99 a month, you're going to see me four times a week, 4 times a month. We're going to do classes together where you can download your images. I have a tool that I use called Collective Minds Radiology. It's basically an amazing mobile PACS, and they are, we're able to take and de-identify your images. You can download them and present them, and we can talk about them in class. So there's a lot of benefit, and I look forward to seeing you all in class. Thank you so much. Dr. Barrett, I really can't thank you enough for reaching out. You really elevated my idea that this is, something to share. And every day I'm more convinced that this sharing of this knowledge is the best thing I can do in medicine. And it makes me feel good for being here. So thank you.
You should feel anytime you can educate and empower other people to carry on your work, that's the ideal, because there's only so much you can do. But Marlena, thank you so much for coming on. I look forward to having you back again. And I think maybe we should just talk about plantar fascia.
We can talk about whatever you want. I have no end to how much I want to talk about these things, and it's been a pleasure. Thank you very much.
Thank you. This episode is sponsored by Savant Cellars, providers of boutique Tier 1 Reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at savantcellars.com. That is CEVANT sellers.com. Spelunk15.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, potofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.